This is Dr. Sonal Mehta, Lead Medical Advisor, INTAS. INTAS Pharma Company is a leading pharma company headquartered in India, having presence in more than 80 countries. And being a knowledge partner and a science-driven company, we have organized this webinar. INTAS Women Health team, headed by Mr. Satpathy, has organized this webinar. I welcome you all to this webinar on endometriosis and infertility and ART. Today, we are fortunate to have two eminent faculties, Dr. Abayomi Ajayi and Dr. Prakash Trivedi. Dr. Prakash Trivedi will be speaking on endometriosis infertility surgical aspects, and Dr. Abayomi Ajayi will be speaking on endometriosis infertility and ART protocols. So Dr. Abayomi Ajayi is the Chief Executive Officer of Nordica Fertility Center, Lagos. He is co-founder African Endometriosis Awareness and Support Group Society. In 2003, he started Nordica fertility centers in Lagos, pioneering a wide range of ART practice across the nation. He also established a platform called Dr. Abayoma Ajayi Physicians Mentoring Program, wherein all the doctors can stay abreast the latest breakthrough in the fertility management and ART. Dr. Ajayi has authored many publications and delivered numerous lectures in national and international conferences. Is member of many associations, Nigerian Medical Association, Society of Obstetric Gynecology, ASRM, AAGL, ISGE, and American Society of Liposuction Surgery, and whatnot. Dr. Prakash Trivedi is the pioneer laparoscopic surgeon. He is Professor Dr. Prakash Trivedi, consultant gynecologist, endoscopic ART, urogynecologist, pioneer of histoscopic surgery, laparoscopic suturing, 3D light laparoscopy, in-bag morcellation, urogynec in Asia. His director, Dr. Trivedi, Total Healthcare Private Limited and Akar IVF Center. He is current president ISA 2020-21. He is past president Foxy 2015, IAGE 2013, 2015, scientific chair of AAGL in India 2016 and 20. He has received almost all the awards, received Young Scientist Award 1995 for hysteroscopy, TCRE, received Health Minister Award, Research, Fibroid and Infertility, AAGL New Research Breakthrough in Bag Morcellation Fibroids. His hospital is recognized by Maharashtra University for training post-doctoral fellowship course in minimal access surgery. He is innovator, skilled surgeon, pioneer laparoscopic surgeon, teacher in demand, and motivator. Published 9 outstanding international teaching books and 18 education CDs and DVDs. With this, I welcome Dr. Abayoma Ajayi and Dr. Prakash Trivedi, sir. Over to you, sir, Dr. Prakash Trivedi.
Thank you very much, and it's a great pleasure and privilege to participate and be a part of this lovely webinar. I hope I have shared the screen with you. So it's actually a great honor and a privilege to be part of this very interesting webinar. And personally, it's my pleasure to be along with a veteran like Abayomi Ajayi. And endometriosis is a subject which is the disease of the millennium. And my job today will be on highlighting on current management of endometriosis infertility ART, more related to the surgical perspective. We have to understand that nobody has understood endometriosis, and there are many unanswered questions. And I share this with Professor B.N. Chakravarti, Nezat, Arno Vatiers, Kickstein, Marcello, Mark Possover, and so many others with whom I have worked together. And this is a cumulative knowledge which I will be presenting to you more than 30 years, but with the best experts. We have to understand the biggest problem in endometriosis is not with me or Ajay, because the biggest problem is more than 64% of the endometriosis is before 30 years of age. And what happens is, whether he gets or I get, these are the cases which are already being managed. By management, it may be well managed, it may be messed up, whatever it is. You don't have a choice. So managing endometriosis really starts much early. Of course, in adolescent, I will not go into detail, but keep the laparoscope away. Don't be in hurry to operate a young patient. You always have to think whether if it was my daughter or my daughter-in-law, whether I would have operated. Because even if you operate at 19, she will get a recurrence at 23. So you have to be very concerned when you will really operate an adolescent for severe dysmenorrhea. And in today's time, we have to remember many of them are sexually active. The most important thing, everybody feels that let me put her on some oral contraceptive, let me put her on some progesterone, and the common feature is let's wait. And there is enough evidence by HRI guideline development group clearly suggesting that any hormonal therapy prior to infertility treatment in endometriosis doesn't make any difference in terms of treatment of endometriosis. So you have to understand, very often most of the people have a laparoscopy setup wherein they have a diagnostic laparoscopy, which actually in our center we do 600 plus or even more operative procedures in a year, and a diagnostic maybe one or two. So when you have mild or minimal endometriosis, there is data to suggest that if you have a bipolar or something, then you can as well treat them rather than keeping them on expectant management. Because it is found that if you are treated at that time, instead of keeping on expectant management, you will get much better result by treating the endometriosis. Now, I personally believe no female is endometriosis till they are tissue diagnosed. And as you can see over here, this is a wide excision of an endometrioma. You can inject some fluid. You labeling any patient as tuberculosis and endometriosis, you should have a valid evidence. Anything which is red, chocolate, they used to tell raspberry, strawberry. I used to add Cadbury for chocolate. So you have to understand that diagnosis is based, of course, we can detect by sonography, etc. But a tissue diagnosis is very much important, which can be done through laparoscopy. But you're not going to do a diagnostic laparoscopy to confirm whether she has endometriosis or not. Now, 176 million women globally have endometriosis, of which 26 million is the contribution from India. So it is a very important part of any gynecologist, any infertility specialist, any laparoscopist, any conventional surgeon, because they may present with pain, infertility, dyschezia, dyspareunia, and many other things. Now, the medical treatment is very interesting. The name itself is pseudo pregnancy and pseudo menopause. In 1997, I was in India, in Mumbai, in my big conference with Kamran Nezad and Jack Donis together. And we realized that pseudo pregnancy and pseudo menopause, which means the treatments are pseudo. You make them feel like they're pregnant. You make them feel like they're menopausal. So this never treated. They only suppressed endometriosis. Further, therapy has to be cost effective, tolerable. Physician has to have sufficient experience. And as I told you, a lot of things you can diagnose by a PV or a sonography. Just now, just prior to this, I was just doing one patient of fibroid referred to me. I was just doing a sonography and I couldn't find clear evidence of endometriosis in that. So you can make a diagnosis. You don't need a laparoscope. Obviously, when you have endometriosis, there is nothing to jump and start laparoscopy as the treatment, because there are enough evidence to suggest that if you do a controlled ovarian stimulation with IUI, it has 3 times higher pregnancy rate than just doing IUI or just doing COS alone. And the beauty about this is a large number of them are spontaneous pregnancy rate within first 6 months. Live birth rate also increases. ESHRI EGDG 2013 COH and IUI increase spontaneous pregnancy rate within first 6 months, especially for stage 1, stage 2 endometriosis. Now, we have an IVF center for more than 20 years. I am the president of Indian Society of Assisted Reproduction. I have a lot of interest prior to that, and after we started even IVF, 30 years, I have extensive experience in laparoscopic management of endometriosis, which changes in every decade. Because you're only a laparoscopist, your vision to do laparoscopic surgery is different. If you're only ART consultant, your vision is different. If you're both combined, or if you have too many ART friends, which I have, then you are wiser by understanding through the ART consultant. Apart from women's age, any previous surgery, as I told you, 64% of them will be treated by somebody else. What is our ovarian reserve? Apart from AFC, AMH is useful. Medical treatment. Quite often people are forced to have a depot, forced to have danazol, forced to have some tablet, which has no connection of whatsoever nature to improving the fertility outcome. And in endometrioma, giving all this is like giving antibiotic for an abscess. Dunes, myself, and Nizat, all three in 1997, clearly told that danazol only deserves, it's like paracetamol for headache. Now, it's very important for a laparoscopic surgeon to understand. Very often we really don't go into detail, and this is the most important slide of my presentation apart from other slide. When the blood goes back and deposits on the ovary, blood essentially has a lot of RBC. So obviously there is iron which gets sequestrated by macrophages ferritin. All these macrophages are overloaded with iron. So what does macrophage do? They try and destroy this iron and generate a lot of superoxide and hydrogen peroxide ions. Now, these are pro-oxidants. So, iron itself induces oxidative stress. So, it's not just cyst, it introduces stress which generates fibrosis, which reduces the utilizable cortex specific to stroma, which leads to smooth muscle metaplasia and decreases the microvascular density. So this affects follicular maturation, follicular density, reduces the oocyte maturation, reduces the number of oocytes available. More important that even if it is available, suppose if you have a patient of PID or PCOD and you have an endometriosis and you use in donor oocyte, endometriosis will have less result because it reduces the chance of fertilization, IVM, reduces the chance of implantation, it reduces the chance of blastocyst formation, and also it increases the chance of abortion. Increase apoptosis and follicular oocyte index is important, which is very simple index. It should be more than 50%. Means if you see 10 follicle, you should have at least 6 oocyte. Rectovaginal endometriosis needs a special mention because there's a lot of rectovaginal endometriosis globally, not necessarily in India, not necessarily in Africa. India and Africa are popular for fibroid. We have fertilization industry for fibroid. We have as many fibroid as we want. But if the patient is having infertility as a main complaint and rectovaginal endometriosis not as a main complaint, which you can detect by ICG and imaging, it's not necessary to treat that rectovaginal endometriosis in urgency for fertility benefit. Now, this is a very important thing I want to tell. This is an endometriotic surgery. If you can see, this is a standard endometrioma. So I'm injecting diluted vasopressin, like as if I'm doing a dermoid. So surgery was different earlier. Now, this helps us to create a nice plane and a space between a pseudocyst, which is a cortical cyst, the endometriosis. You will partially open it. Obviously, we all know that pseudocyst is going to break. So at this moment, you drain the endometrioma. Now you have drained the endometrioma. There is no debate that the walls of the endometriotic cyst, the first surgery is the best surgery. So now I re-inject vasopressin between the cyst wall and the normal ovarian tissue. What happens with this, you can see in front of your eyes. The entire peeling off process, if you see, I'm having an atraumatic forceps holding the capsule of the endometrioma. You are removing the disease. Don't panic that our AMH will disappear. There's a huge panic with fertility consultant that any surgery, first surgery, if it is done properly, and the fact of the matter is 75% of laparoscopic surgeries done for endometriosis is not correct. And that is the reason why you have to see that you do a correct surgery. And after doing a surgery, there is no need of enormously coagulating the remaining part. There is no need of suturing and causing. Take the specimen and do it. Only sparingly use a bipolar so that it takes care. And then put her on active fertility treatment. Don't wait for 6 months or 7 or 8 months because that's the best immunological time when you can have pregnancy. Now, if I have done a cyst like this, how do I treat them? Immediately after that, I would not wait for more than one cycle and then start with treatment. I prefer to use dydrogesterone 10 milligram twice a day from day 5 to day 25, along with giving tablets of ovulation induction, which is letrozole, my preferred one, enclomiphene from day 3 to day 7, add FSH on day 6, day 10 to improve the quality of the oocytes. And once the follicles are 18-20 meter plus, you'll give a trigger. You will do an IUI and you will support them with a vaginal progesterone. And I use dydrogesterone because it is more specific for endometriosis and an immune modulator. So no depot, no danazol, wait for one cycle, and you have most of the pregnancy in the first 6 or 7 months rather than waiting thereafter. One of the largest study of laparoscopic surgery with 11 years follow-up is by Italian Cocascio group, wherein 44% at stage 1-2 disease, 56% at stage 3-4 disease, laparoscopic surgery was done. Average pregnancy rate was 37%, 48% in stage 1, stage 2, 28% in stage 3, stage 4. But very interesting point, if you see the next sentence, if laparoscopic surgery is done and you resort to IV efficacy, especially in stage 3, stage 4, the pregnancy rate is 64%. So if you're a conventional surgeon, if you're a laparoscopic surgeon, don't hold. Trust the ART expert in your area, whether in India, in Europe, in America, in Africa, anywhere. You have wonderful ART people, trust them. And if you do a good surgery, trust the laparoscopic surgeon because spontaneous pregnancy rate is 23.2%. Oral abortion rate will remain around 16%. And maximum conception takes place in first 6 months. It is dropped thereafter, especially 1 year. And if the age is more than 35 years, again there is a drop. This is an important patient. I had operated her with 20 weeks bilateral endometrium, and this is the surgery which I had done. Evo Brussens and Dunez concept. Make a fenestrum, minimal bipolar coagulation. Now, this patient was from interior from our state only in Maharashtra. This is when she came 4 years after marriage with husband's count of 4 to 7 million, and she could not come for fertility treatment to us. So this is the surgery we did, which was a repeat surgery. And if you see, most of the ovarian tissue is kept. We have just bipolar fulgurated. We put her on dydrogesterone twice a day from day 5 to day 25, 10 milligram. And we started letrozole. And with 4 to 7 million, 9 years back, she had a spontaneous pregnancy, a daughter. And then subsequently, she had one more pregnancy. So when you do a repeat surgery, you have to be careful, but you have to be master to do minimum and put her on an active fertility treatment. Now, EGTG guideline September, is surgery effective in infertility associated with endometriosis? Proper operative laparoscopy increase pregnancy rate in stage 1, 2 rather than doing a diagnostic. Excision of endometriotic capsule improved increase in spontaneous pregnancy rate compared to just fulguration and keeping a lot of residual disease. Even in stage 3, stage 4, operative laparoscopy, if it restored the anatomy, spontaneous pregnancy increase. And if you went to ART after that, it even increased the result. Repeat surgery should not be done, should not be taken lightly, because it definitely reduces the ovarian reserve. We do use a depot preparation, especially when there is an inflamed endometriosis. Inflamed endometriosis, if the patient is having dyspareunia, when you do PV or sonography evaluation, there is significant amount of pain and discomfort. You have frozen pelvis, you have recurrent endometrioma, you've done a laparoscopic surgery, and you find a significant amount of disease is still left. Rectovaginal endometriosis, and especially prior to starting an IVF cycle. So you will be using a depot in selected patient. You may be using a long depot when you are going for an ART, which Dr. Ajay will be covering. This is a slide which he will be covering, only simple to mention. You need higher amount of gonadotropin, you get lesser number of oocyte, you have higher abortion rate, you have higher cycle cancellation rate, you have less blastocyst formation rate. Again, stimulation in ART. I'll skip this because this is Ajay's department. We have a different protocol, but when we discuss the Q&A, I will discuss with you what do we do when it is less than 35, what do we do when it is more than 35 years. I would not encroach in his area of expertise, which he will cover. When you're doing an OM pickup, and I have done thousands of OM pickup, we have around 8,000 IVF pregnancy, and I'm least worried about a small endometrioma if it is present. Smartly, you do a pickup of the other ovary, finish the follicle pickup from the ovary which has endometrioma. Accidentally, if you have punctured an endometrioma, don't give those Falcon's tube to our lab. My wife is an embryologist, and she always mentioned that it really doesn't make any difference. Even if there was some chocolate, they can identify the cumulus and oocytes much more easily. So don't panic too much. There are many people who change the needle, but it's their individual choice. We always believe in ICSI and always believe preferably if there is enough embryo then to do blastocyst transfer. Antagonist. Everybody talks only about antagonists, but current evidence clearly says that if you have a agonist protocol, you have a high number of M2 sites, and a lot of people are returning back to the long protocol. But that again, he will be. When you're talking about endometriosis, today only I just saw maybe 45 minutes back a patient of fibroid adenomyosis and endometriosis. So when you have an adenomyosis, I have removed 12,000 fibroids. I name any number of fibroids, I have removed sizes. But check of a good laparoscopic surgeon is how they do localized adenomyomectomy. So this is a localized adenomyomectomy, which was of one of my nursing staff's relative, failed IVF. So if you see here, I have injected vasopressin. I'm using Caesar to get into the right plane. So I get zero point 0.7 centimeter of thickness towards the serosa. Don't open the endometrial cavity. Once you are on a song, then you can use harmonic and dissect. So dissect optimum amount of adenomyomectomy. By optimum, I mean zero point 0.7 towards serosa, zero point 0.7 towards the endometrial cavity. Here, if you can see, the entire endometrioma is nicely removed. And I'm intentionally showing you use of Vicryl because interrupted Vicryl was the first choice, because sometimes you cannot close the endometrioma very easily. So your suturing skill has to be way ahead. Nowadays we have V-lock, but V-lock is not an answer to all. Remember, if you can close a burst abdomen with one layer, you can also close a localized adenomyoma. I don't believe too much in surgery for diffuse. This patient, after the first attempt of IVF, she conceived. This is our in-bag morcellation. We have 500 plus cases of in-bag morcellation of fibroid and any suspicious tissue. Very important about this patient is that she, uh, when I did cesarean section, it was very interesting because I removed a child, I removed the placenta, and I realized the hole in front was smaller than the hole on the posterior wall because it was placenta increta pancreta. So the posterior hole was bigger than the present hole. This is another interesting thing. We have 5 sonography machines, so we pick up. So this was an adenomyoma which was very close to the endometrial cavity. And I have at least 10,000 plus hysteroscopy learning from France, from Clermont-Ferrand, and many other centers. I am very clear. I know there is a posterior wall adenomyoma. The tubes are well seen. So I go ahead and do a resection because you see that bulge. That bulge is not the fibroid, because on sonography we could identify fluid content inside. So once we resect the thing, you may use bipolar, monopolar, it's your choice. But you're very sure that at 12 o'clock you have an endometrioma. So when you resect, suddenly somebody who is new in your operation theater will feel, oh, there is a perforation. So go ahead and resect. So I am resecting and you can see something behind which looks like a perforation. It's not a perforation, because if it is a perforation, your distension will go away. You can see chocolate material coming out. So this is an adenomyoma which is closer to the endometrial cavity, and you can very well resect the adenomyoma which is closer to the cavity. This will give tremendous relief to our pain and which will improve. And if you can see, it's not a small space. And why I'm telling it's not a perforation, because it's a good line. There is no momentum seen, no bowel seen. So systematically you resect, you will be lucky to have such an. So you have to master the art of laparoscopy, you have to master the art of hysteroscopy, you have to understand fertility, you have to understand endometriosis, and you have to remember principles of assisted reproduction. So once we've resected this, obviously we'll not be in hurry to do anything. There is no need to give any long medical treatment. You can just give a depot, and one cycle later, you can straight away take them for treatment for fertility. So that is the adenomyosis, which is detected by ultrasound. A lot of people are always worried about rupture in adenomyosis, and it's correct. We don't believe in Osada's technique and doing too much of surgery, multi-layer, etc., etc. For the simple reason is that you're removing a lot of normal tissue wherein it's not going to benefit in fertility. What leads to rupture is not necessarily your instrument, not necessarily your use of cautery, not necessarily any aspect, but the most important thing is the wound healing after fibroid, which is a pathology which goes out. Then it's all myometrium. In adenomyosis, when you have done it, you have kept some amount of adenomyosis. So what happens is when the scar heals, if there is more inflammation, there is more hyper granulation, there is less angiogenesis. So remodeling takes less, there is more collagen deposit, growth factor needed for rejuvenating reduces. So that scarring is the scarring which leads to reduce weak myometrium and blood flow, and then there can be a rupture. So you have to be very careful in such situation. When you have 16 weeks plus adenomyosis, there is no point in doing any surgery. Give depot for 2 to 3 months and take them. But in spite of whatever you do, you will have less pregnancy rate and you will have 67% abortion. So basically, you have to remember that adenomyosis can affect a lot of things. Endometriosis may be preferred over adenomyosis. To give a take-home message, you have to remember there is hardly much medical treatment which is available when you're talking about fertility and endometriosis. One good drug can be a dydrogesterone. When you are treating endometriosis with stimulation, COI with IUI, stage 1 to endometriosis less than 35 years. More than 35 years, don't wait for IUI, refer it to Ajay. Stage 3, stage 4 endometriosis associated with infertility. Conservative surgery if necessary. Don't wait for long. Refer it to a proper ART consultant. And most important thing is trust and believe in IVF ICSI, because when they have a good ovarian reserve, they can produce adequate amount of quality oocytes and good embryo. Recurrent endometriomas should be avoided for surgery, and adenomyosis, as I told you, your pregnancy rate will be less and your abortion rate will be 67%. To conclude, if you chase perfection, you can catch excellence. And you have to believe in your belief, doubt every challenge till the ultimate truth comes out. Endometriosis, apart from laparoscopy and surgery and other aspect, all the remain will be very well covered by Ajay. And after that, we will have the question answer session. It's truly an honor to be part of this wonderful webinar with INTAS and with Ajay and everybody. Thank you very much.
Thank you, sir, for giving a very insightful talk with lovely videos of operative procedures and with your tips and tricks for all the procedures and management part. I'm sure our viewers have much benefited with your talk. With this, I welcome Dr. Aboyama Ajay for his talk on AR, endometriosis, infertility, and medical management.
Thank you so much. Thank you so much. I'm going to share my slide. Yes, it's a pleasure to be invited to speak at this webinar and to talk about the topic that we all care about, endometriosis and infertility. And it's also a pleasure to be speaking after Prakash, who has done a good job on the role of surgery. So basically, I'm going to concentrate more on the role of assisted reproductive technology. Well, my name is Dr. Abayomi Ajayi. I run Nordica Fertility Center in Lagos, in Nigeria, because I have 3 centers, one in Lagos, in Asaba, and Abuja. And for my disclosure, I really have nothing to disclose. Everything I say will be the truth and nothing but the truth. I'll start by defining what endometriosis is. We know there is the presence of endometrial-like tissue, either glands or stroma outside the uterus, and which induces a chronic inflammatory reaction. So we're talking about inflammation when we're talking about endometriosis. But not only inflammation, we're also talking about controversies. And then there are a lot of controversies about what causes endometriosis, to the prevalence, to the symptoms, even to the effect on fertility, what we're talking about today, and how to manage. All right, so we try to touch on some of this. And I start with the prevalence. And one paper that I like is the one by Giazzi, and which is a paper that was just released February this year, shows that the issue of prevalence in endometriosis is always either the over or underestimation of endometriosis. We don't even know the prevalence of this disorder in our community. So it depends on where you're looking at it. If it's a hospital-based figure, it's likely to be overestimated. If it's a community-based figure, it's likely to be underestimated. And so that's one of the things that we face with endometriosis. And then if you're looking at from diagnosis point of view also, we'll see that from that same paper shows us that infertility, when you're looking at people who have infertility and have endometriosis, approximately 25% of some fertile women have endometriosis. Still talking about prevalence, another paper from Israel shows us that which looked at about 2 million people and saw that about 1/3 of women who have infertility actually will also have endometriosis. And so this prevalence, even starting from prevalence, we don't seem to agree on what the prevalence is, depends on where you're looking at it from. Then when you come to symptoms, also we see that there is no symptom that is pathognomonic of endometriosis. You cannot say if you have this symptom, then you have endometriosis. And that we sometimes call it a masquerade of a disease. It has caused so much delay in diagnosis that majority of the people, especially in the developing part of the world, probably don't get diagnosed on time. Even in developed parts of the world, we know that there is delay of about 4 to 7 years in diagnosis. So majority of these people are misdiagnosed, they are mislabeled, and they are misunderstood. Sometimes some of them are on anti-tuberculous drugs for no reason. Now, in my center, we did a 10 years review of what the symptoms are like. And what we saw was that this was published in the Journal of Endometriosis and Pelvic Pain Disorders in 2016. And we saw that 73.8% of our patients had dysmenorrhea. And so we thought that was a predictive symptom of endometriosis. Then interestingly, 62.5% of these patients had severe endometriosis based on laparoscopic evidence. And also interestingly, about 52.5% of these patients had blocked tubes, either one tube or the 2 tubes were blocked in them. And therefore, we saw that there was a big need. Of course, it was not surprising if the majority of them had severe endometriosis, that also the tubes were involved. And therefore, ART is a very important aspect of the management of endometriosis, at least in the population that we reviewed. Now, what is the reason why endometriosis, what is the relationship between endometriosis and infertility? We still don't even know that because we know there is no causal relationship, though we know there is a strong association. Yeah, de Ziegler mentioned some of these things that might be responsible for the infertility that we find in endometriosis. Well, some of them, the pain from dyspareunia, the mechanical distortion, the inflammation that accompanies this, and then, of course, sometimes also the presence of adenomyosis. Now, one thing we are sure of is that the fecundity or the ability to get pregnant every month is reduced in patients with endometriosis, while people who don't have endometriosis in their young age below 35, the risk of, or the capability to get pregnant is about 15 to 20% per month. The fecundity in people with endometriosis is about 2 to 10%. But what we also found out that this problem is not only with infertility. Almost every aspect of their lifestyle is affected. And this paper on the impact of endometriosis on quality of life and work productivity shows that very well, that majority of the people are always dealing with pelvic pain. And there's a study that was just released this year in Poland, which looked at the quality of life of 308 women in Poland and showed that the lowest quality of life was in the physical domain. That is, they had lack of satisfaction in everyday life and work capacity. So when this is now accompanied by infertility, is a big problem. Now we're going to where the rubber meets the road, which is the management of endometriosis. Like Prakash said, I mean, the medical treatment, I think that's the only thing we all agree on endometriosis, that medical treatment is not useful for infertility. But the most appropriate treatment for endometriosis-related infertility is still a controversy. Well, there's a handshake sometimes between surgery and ART, and sometimes one has to go alone. Either it's ART or sometimes it's with surgery. But just like I said, I mean, we know this H3 guideline says very clearly that there is no place for hormonal treatment or drug therapy when you are treating infertility that is related to endometriosis. And then Prakash also said this. I mean, we can see that the effect of surgery on endometriosis. But of course, this usually is the early stage endometriosis. And one thing we can see from this graph is that it's better to be doing laparoscopic surgery than diagnostic laparoscopy. And therefore, the skill of the surgeon is important. Diagnostic laparoscopy should be discouraged in endometriosis. Now, we also see from that graph, which is better illustrated here, that the fecundity increases for over 36 weeks after a well-performed surgery. So, you know, we said that the women with endometriosis, their fecundity is reduced to 2 to 10% per month from the 15 to 20 that normally young women have. Then this doubles over the next 36 weeks or 6 months, just like Prakash said, whereby they have a risk, or they stand a chance of getting pregnant spontaneously or with mild treatment like IUI, like anything. And that's why, just like he also said also, this is for surgery, the ASRM, the early stage of endometriosis, stage 1 and 2, are good for surgery. But one thing I want to leave you with before I go to my own bit is this endometriosis fertility index, which is a good tool to use after surgery to be able to tell you what next to do for your patient. All right. With this, you can look at this was proposed by Adams and Pastor in 2010. And the thing to look for is an end of surgery score. So after you've done your surgery, you can assess the situation of things. Look at what we call a least function score, all right, where you look at the tube, you look at the adnexa and then the ovaries and then give the scoring to them and look at the history of the patient. That's the factors that are responsible for conception, like the age, whether the woman has had a child before, and so on and so forth. And then you can now use this to be able to categorize the patient into those who need immediately to go either into ART or those that you can do some other things with, like IUI, like letting them wait, because there's some patients really and truly, they have no business to wait for spontaneous conception. And this is one proposal for clinical use of the endometriosis fertility index. When the index is low, then the patient should go for ART immediately, all right? If the male factor is not very good, then also this patient should go for ART, you know? But if it's medium and also there's severe male factor, ART is the business, is what the patient should go into. But if the EFI score is high, and there is no male factor, such a patient you can conveniently, and then she's young, you can conveniently tell her to, okay, wait for 6 months, either she's doing IUI, she's doing, which gives, just like Prakash said, gives better result than just expectant management. Or you are doing, you're just doing IUI, just like you said. So, but what is the role of IUI? This is where the rubber also meets the road. We're now going straight into ART proper. Now, is there a role for intrauterine insemination with endometriosis? This is $1 million question. Yes, it is true that the ESHRI recommends this, NICE recommends it, but one thing we know is that also, even in their own recommendation, what they're saying is that it's better with ovarian stimulation, you know, and that the role of unstimulated IUI is uncertain. That's what the guideline says. Now, but we also know that with the presence of endometriosis, the success rate of IUI is reduced to between 30 to 50%. And so some bodies like the Endometriosis Treatment Italian Prop says that this, you should not even try IUI. But of course, like everything, as we're going to finally conclude that you need to individualize each patient and see what you need to do for the patient. But IUI is something also that we need to look at very closely when we're talking about ART and endometriosis. So the main ART for endometriosis actually is IVF, and is usually recommended when endometriosis is associated with tubal function compromise, or there is male factor infertility, or when other treatments have failed. Maybe you have done your IUI 3-4 times and it has failed. Definitely you must be looking at IVF. Now, one of the things that we also know is that the effect of endometriosis on ART outcome is still controversial. So I'm just going to go over some of the evidence that we have looking at the effect of endometriosis on ART. Well, I think one of the earliest meta-analysis done on this subject was done by a gentleman called Barnhart from the University of Pennsylvania in the US. And he reviewed 22, he did a meta-analysis of 22 observational studies. And these were papers that were published between 1983 and 1998. And he looked at endometriosis versus controls. The control was actually with tubal infertility. And he looked at the implantation rate, the number of oocytes. He saw that there was reduced number of oocytes. The fertilization rate was lower. The implantation rate was lower. And of course, pregnancy rate was lower. Then he also saw that this reduction was worse in patients who had severe endometriosis as compared to people who had mild endometriosis. So that was the result that Barnhart came up with. So, but over time, people were saying, okay, fine, look, we need more current figures. So in 2013, HAB also did a systemic review and meta-analysis. And in this paper, which he published in British Journal of O&G in 2013, the effect of endometriosis on IVF outcomes. And he saw that there was reduced fertilization rate in stages 1 and 2 endometriosis. And there was reduced implantation and pregnancy rate in stages 3 and 4. This reduction in stages 3 and 4 in the implantation rate was about 21%. And so we can see that there is the papers that were, the older papers showed us that, look, endometriosis affects your IVF outcome. But now we also have some other papers that are probably not saying that in such a way, because they're telling us that live birth rate might not decrease in patients who have endometriosis and are doing IVF. Okay, so this lady, Senepati, Sunita Senepati, from the University of Pennsylvania, also did a review, which was a retrospective cohort study using the Society of Assisted Reproductive Technology, that's the American body, the database she reviewed the database retrospectively and looked at the figures between 2008 and 2010. And our outcome measures were to look at live birth rate, implantation rate, and oocyte yield. And she saw that there was reduced oocyte yield when you have endometriosis. But she also saw some things that when it depends on the kind of endometriosis, whether endometriosis was occurring alone as the only reason why there is infertility, or there are other factors, okay, which she called endometriosis plus. Remember, in the figures that we also did in Nigeria, we saw that about patients, about 52.8% of the patients had tubal factor. So she looked at this, and the factors that she was looking at was the tubal factor, she was looking at the male factor, and she was looking at reduced ovarian reserve. And she saw that when in about the patients who had endometriosis, only 36% had only endometriosis. The 64% had endometriosis plus other problems. And so the implantation rate and the live birth rate in these people were reduced. And also, this is one other thing I want you to see, this figure that shows that miscarriage rate doubles in patients who undergo IVF with endometriosis. Now, so these figures all show us one story. Some of them don't say it the same way, but one thing some other things we can deduce from this, that there are fewer oocytes when you have endometriosis. Now, also, whether the quality is reduced or not is also a source of controversy. Yeah, some people have said, okay, fine, they've been able to see that there is really no problem with the oocytes that you have from patients with endometriosis. Why some people have said no, there's reduction. They've talked about the reduction in the granulosa cells, the P450 aromatase expression that they're talking about. And just like Prakash also said in his presentation, the increased reactive oxygen species that are found in these follicular fluids, which might reduce the quality of the oocytes in this. But also one thing that we know is that there is increased cancellation rate. And this is very important when you have a patient who is going to go through IVF with endometriosis, that this counseling, you should counsel them from the get-go about the chances that they might have. The cancellation rate in people like that is more than the other people who are doing IVF for other reasons. And the implantation rate also, there is this controversy, whether it's reduced. Some people say it's reduced, some people say it's not reduced. And people are always arguing, is it the embryo or is it the endometrium? That argument I really don't want to enter into, because I think it's the story of the chicken and the egg. The two are affected. There is no doubt about that from my own point of view. So, but let's look at some of the things that people have also tried to do to improve pregnancy rate in patients who have endometriosis who are going through IVF. Now, one of the things is that first started was this issue of routine laparoscopy, especially when you find endometriomas, But there is insufficient evidence to say that it helps at all. And we know just from what Prakash also said, that we need to be careful when we have endometriomas and we're going to do IVF, because there is a risk of ovarian damage. Of course, we know that this might also be dependent on the experience of the surgeon, but we now know that we don't need to chase after endometriomas just because we want to do IVF. For you to remove endometriomas, there are indications for the removal of endometriomas. So it's not every endometrioma that you see that you have to chase after. There was a time that we thought that might help us to improve pregnancy rates by removing them, but we know that's not true now. But you might consider that maybe if you have a failed assisted conception treatment, but we know that there are indications for endometrioma removal now when you are dealing with infertility. And so I'm going to look at endometriomas, the next thing. Yes, how to treat endometriomas. We know that endometriomas are common in endometriosis. Actually, Goodies in 2004 reported that it can be present in about 17 to 44% of women with endometriosis. And Hamdan from Malaysia, with the team from Southampton, did a systemic review and meta-analysis and saw that the number of oocytes are reduced when you have endometriomas. There is increased cancellation rate compared to people who don't have, who are doing IVF. And then the pregnancy and live birth rate actually remains unchanged whether you do surgery or you don't do surgery. So that's why we stopped doing surgery for endometriomas, just because there is endometrioma in place. There is no change in live birth rate. And that's what this is telling us. Of course, like Prakash also said, FSH dose might be increased because Kitayama, the Belgian group, were able to show us that there is something called a burnout, which the follicular burnout, which can result from just the presence of endometrioma on their own. So right now, just like I said, we need to be cautious with endometriomas. We don't have to chase after them unless there is either we suspect that it's rapid growth and we're suspecting there might be the chance of maybe cancerous transformation, or we look at the scanning now where we think something is suspicious that is going on there. We might need to do surgery for endometrioma, or there is pain, or we see that we cannot get, we're going to have problems when we are going to do ovum pickup when we're doing IVF. But patients who are older patients also, and those with low ovarian reserve, we really need to be very careful about these patients. And so endometriomas need to end surgery. It's not every endometrioma that we must operate on. Then the other thing that I want us to look at is this issue of prolonged downregulation. We know that Salam came with this in 2006 with this Cochrane study, which concluded that if we applied prolonged downregulation for 3 to 6 months before IVF, that increases the clinical pregnancy rate up to about 4-fold. I'm sure many of us who have been practicing probably don't have the same experience. And so this needed to be updated. And it was not surprising that in 2019, there was an update from a group in the UK with Georgios as the lead author. And they did a Cochrane review as well, looking at 8 RCTs and 640 patients. And they saw that the live birth rate, the overall complication rate, clinical pregnancy rate, multiple pregnancy rate, miscarriage rate, and the number of oocytes retrieved were not affected by this long GnRH agonist. So right now, there's so many things, many people have stopped doing this prolonged GnRH downregulation, including myself. And also there's always the debate about the kind of protocol, the agonist or the antagonist. We know that now, yes, the data is limited, but we know now that there is no advantage in using one over the other. And so you can use anyone that you are comfortable with, either the agonist or the antagonist. You're welcome to do that. And we also know that if you need to be careful when you are doing your OPU, just avoid the endometriomas as much as possible. But if, just like Prakash now said also, if there is contamination, you don't need to really worry your head about that. And one thing that I also want to look at is this deferred embryo transfer, which Bodon showed in his study in 2017 that there might be advantage in that. That's what this means, is that you pick up your eggs in one cycle, do your IVF, and then you replace the embryo in another cycle. So frozen embryo transfer. Of course, for you to do that, that means your vitrification technique must be good enough. And once that is okay, I think the results are very, very encouraging. It's one of the things I think we also need to look at. And it makes a lot of sense because we know that we just said, majority of the patients who have endometriosis are going to require higher dosage of FSH. And therefore, it's likely that the endometrium and the embryo might not be in sync because of the dosage, the estrogen level that will have occurred because of your high dosage of drugs. And so it probably makes a lot of sense to transfer in another cycle. So that is one thing that people are looking at now. And this also, fertility preservation in ART, especially for endometriosis, is also one thing that is getting hot. Actually, the last HT meeting, though, was an e-meeting. This was one of the papers that was presented on that, on fertility preservation in endometriosis. And this might be very important for young women who don't have immediate plans to get pregnant, or patients who have bilateral endometriomas, and definitely for people who have recurrent endometriomas. This is one thing I think we should be looking at, and then that we should consider for these patients who are going through infertility treatment, or who are facing infertility with endometriosis. So I'm just going to conclude and say that IVF or ART remains the most widely used method to combat endometriosis-related infertility. But before you undertake that, a comprehensive fertility assessment is necessary in all patients. And the things to look out for, you must consider the age, whether there is a male factor present, whether there is tubal patency. Of course, you know, if there is tubal patency, the tubes are blocked, they're not going to consider IUI at all. Whether there is hydrosapinges, do you need to chip off the hydrosapinges before your IVF? Those are things that you need to look at. And then the ovarian reserve is something also that you need to look at. And in this environment, like in most other environments, I'm sure like in India as well, the uterine cavity assessment, because we did a study here, we saw that about 61% of our patients had abnormalities in their uterus. So it's important to know whether this patient will need benefit from hysteroscopy before you take her on to IVF. I'll also say that many measures have been tried to improve IVF outcome, but most still remain controversial. Yes, IVF works. Endometriosis might affect your results, but either you keep at it, or sometimes you might have to do multiple cycles. And then since we can freeze, we can defy the ET, and then we look at, those are some of the things that we're looking at in this area of ART and endometriosis. But my take is always that if IVF is required in any patient who has endometriosis, please do it as soon as possible, because time is your enemy also when it comes to that. Because even the presence of endometriomas without even doing surgery has been shown that it reduces ovarian reserve. And counseling of these patients on what to expect is key. Just like I said during my presentation, deferred embryo transfer and fertility preservation are things that we need to look out more for. Thank you so much for listening, and I will expect questions.
Thank you, sir, Dr. Abhayama Ajayi, for giving a very insightful lecture with clear messages. Now we shall take some questions. There are many questions from the audience, but we shall take some of them. Sir, Prakash sir, I wish to know the impact, if any, the decision not to remove chocolate ovarian cyst would have on the outcome of IVF in a situation where the client decides to use donor eggs and decline surgery.
Donor eggs for herself?
Yes, sir.
No. See, endometriomas and endometriosis definitely has an impact on abortion rate. So even if you take a donor oocyte, you will get much better pregnancy rate. So you have to remember that the inflammation and other aspect of endometrioma should be taken care of. So not that it affects massively, but if it is bad endometrioma, then you might as well treat, because you're not worried about the ovarian reserve, because you're taking a donor oocyte, and then give her the best chance of pregnancy. But it is not compulsory to operate all patients. Suppose 3-4 centimeter endometrioma, for whatever reason, probably her AMH is low, response was less. If she goes for oocyte donor, there's no need to operate all endometrioma.
Correct, sir. Ajay sir, how best to use combined OC pills for control of endometriosis pain, interrupted or continuous? This is related to pain.
Okay. More continuous is always better for anything with endometriosis. So if you're using OCP for endometriosis, you're better off with continuous.
Prakash sir, if someone fallopian tubes are blocked by SIN and a surgeon makes opening at both ends from the side closer to the womb, can the person still get pregnancy?
So there is SIN and they opened, incised the SIN.
Yeah, both ends from the side closer means near cornual end.
Both sides.
Yeah.
Both side SIN is not very common, but if both side SIN is incised or excised, obviously the conception will be with IVF. There are some reports we have within India wherein even when doing salpingectomy, if sometimes people have done too close to the uterus, there have been an ectopic pregnancy for the sperm migrating. So even if there is SIN, I think so you have to remember if you're excising, you be little away from the uterus. And obviously the treatment plan will be IVF. Only we have ischemic ectopic pregnancy. So when we have done that and the other tube is normal, therein you can expect that other methods of fertility can be used.
Correct, sir. Ajay sir, what about GnRH analogs before taking endometriosis patients for IUI? Means suppression before IUI. Is it required?
Yeah, it's the prolonged down regulation thing that we spoke about. And right now, it does not have, we don't, the current evidence does not show that it does anything.
Correct, sir. To both of you, they are asking the exact protocol for, say, less than 35 years of patients for IVF and age more than 35 years for IVF. How do they go?
I think so below 35, I can mention. Above 35, sir will mention. It is a little easier. Usually what we do is if we have operated for endometriosis and below 35, presuming that the stimulation, she has reasonable AMH, etc., we give a depot on the second day, a GnRH depot on the second day of period, and start stimulation on first or second day of the next cycle. So she will have a good response, presuming that her AMH and AFC is good. And we can start on, I do prefer a lot of either pure FSH or something like recombinant FSH, which is not compulsory. And when on day 6, we add some HMG. So we do expect a good response in such situation with a starting dose which may vary from 150, and depending on the follicular response and endometrial lining, we'll modify the dose. Suppose if you started on a higher dose, and because agonist was given more than a month back, then they can still have, if there are more follicles which is going to be surprise, then you can still use antagonists on day 6 or day 8 and then modify the cycle. But basically, less than 35, you're always happy with a better AMH in a patient of endometriosis. More than 35, I'll refer it to Nordica, to Ajay sir.
Ajay sir.
Well, age is very important, okay? But I will not be probably straitjacketed about this age and the protocol. Because just like Prakash said, we have to look at the AMH, we have to, because even some 32-year-old with endometriosis, you see that their AMH is already low because of some of the things that we've spoken about all day long, that endometriomas on their own lead to this burnout, that follicular burnout that you described, the iron and so on and so forth. So you have to individualize these patients, all right? So the age alone might not just cut it. And because that's, people like to say, they'll hear, okay, what will you use for under 35? What will you use for over 35? No, it's that each patient, you have to individualize this each patient and see the protocol that will work for them. One of the things I have seen is that the agonist protocol I use mainly for many patients, okay? But the dosage of the FSH is always higher. So, and that, how high it is depends on what your ovarian reserve is. So that's what I'm going to say.
So, sir, what we understand that we should individualize the patient's treatment, and the dosage used for FSH would be higher for age greater than 35 years.
Yes, but more importantly with the AMH.
Right.
Yeah.
Prakash, sir, this is not only related to infertility and endometriosis. What is the present position of neurectomy in endometriosis management?
That's a very, very good question. In 1997, Kamran Nezat, when he was with me in a live workshop, I saw the first pre-sacral neurectomy. And I have done myself 58 pre-sacral neurectomy. In today's time, wherein there is a lot of focus on nerve-sparing radical surgery, nerve-sparing endometriosis surgery, of the 58 patients which I have done pre-sacral neurectomy, there are many patients who were unmarried or nulliparous and were ready to remove the uterus because of severe pain. When we have done a pre-sacral neurectomy, it is really very interesting to know that the relief is significant. And surprisingly, the bladder bowel functions were not massively affected. And price, many of them, when they had delivery, they had more or less painless delivery. So the fact that we always feel that if pre-sacral neurectomy is done, patient will have bowel problem, bladder problem. These are told by many people who have not done a single pre-sacral neurectomy. Of the 58 pre-sacral neurectomy which we have done with different age, of which there were significant patients where along with endometriosis we did, but we didn't find much problem with bladder bowel. So it has a role, but you have to take a guarded consent in today's time, wherein pelvic neurology is a specialty and everybody is talking of preserving the nerve, preserving the nerve.
Right, sir. So, any of you explain the management of mild to moderate endometriosis and infertility without reverting to IVF?
So
They are not ready for IVF.
The obvious choice is Prakash, if he's not reverting to IVF.
Yeah. I think so. Mild stage 1, stage 2 disease, if your scope is in, you just do fulguration. Don't wait for too long. Don't give her danazol. Don't give her depo. If they're keen for fertility, put them on tablets, gonadotropin. As I told you, I do prefer letrozole or N-clomiphene over clomiphene, because letrozole has some marginal benefit on endometriosis. And every time I add FSH to get a better quality of follicle and all, if you're doing an IUI, etc., you restrict to 3 cycles, then modify it. She is very keen that she doesn't want IVF. So usually if you give them letrozole, FSH, and other supportive treatment, I do add dihydrogesterone, which is individual choice whether you use or you don't use from day 5 to day 25, or at least post-ovulatory. Many of them do conceive in the first 6 months. Now, if 3 cycle fails, then that's a patient wherein I would start more of gonadotropin earlier, and then do an IVF cycle. The question once you ask about the GNR at depot, we have one worker in India who was the past president of ISAR. She used to suppress with a depot, and then when she gave gonadotropin and IUI, she got a pregnancy rate of 24 to 28%. But that is an individual person wherein cost was never a restriction, which is not necessarily with all cases. And when a suppression is done, it does more than suppression. The inflammatory and the immunological knockdown which happens in endometriosis, that is improved and that can take care.
Correct, sir. And sir, they are also asking what is the best approach to the management of irregular endometrial thickening due to adenomyosis?
Irregular endometrial thickening due to adenomyosis, to be very honest, there is no treatment. There's absolutely no treatment. You'll do a hysteroscopy, you will do a therapeutic simple curettage, you will not be vigorous. There are a lot of things. Say, for example, there's a drug Dynogest which is used in endometriosis. So there is a drug Ulipristol which can be used for fibroid in some countries. They do have Ulipristol induced endometrial changes, which goes after 6 weeks. So basically, I think so the endometrial changes with adenomyosis and infertility, in any case, decreases the infertility outcome. But if it is not localized, the best thing is to give 1 or 2 depot and take her up for an active ART cycle and try and get results depending on the number of oocytes available.
Correct, sir. Ajay, sir, endometriosis stage 3 IVF management. Again, this is almost discussed, but they are asking.
Yeah, well, we've discussed it. It's just one of the things that we're seeing that people are trying to pass across with all these papers now is that some people are saying that apart from reduced oocyte number, that the moment you even have embryos, that the embryo quality might not be different from other people. And so the paper that Sanchez released earlier this year, Sanchez is from Milan, and what they released this year is that blastulation rate, even from patients with that, which I find difficult to believe, that blastulation rate might not even be reduced. So they're trying to tell us to take our eyes off this endometriosis when you're doing IVF. That the moment you have your embryos, okay, one thing that we've said all day long again is that the receptivity, endometrial receptivity might also be affected. But you know, the studies that they did from looking at ERA to look at endometrial receptivity did not show that. But we know that there is something wrong with the endometrium. So that's why deferred ET is coming in. That, okay, maybe when you get to embryos, do not transfer in that cycle. But the evidence even for that is not enough yet. But it's something that some doctors are doing now. Do your IVF, get your embryos, and then probably transfer in another cycle. So whether you're doing this stage 3 or stage 4, that's severe endometriosis. It's the same thing. The moment you can do your normal IVF, get your embryos, and then you can decide, do you have enough? Do you want to do a deferred embryo transfer? So that's what I think we should be looking at for this.
Correct, sir. Again, question for you only. Do you then down-regulate patients with endometriosis like you would do for other IVF patients? The same has been discussed, but they are asking. Means down-regulation.
Well, the down-regulation, like I said, I mean, the evidence does not show that prolonged down-regulation helps. So if you are not using a long protocol, you are not going to down-regulate. So if you are using a Agonis protocol, you are not even down-regulating at all. So if you are using long protocol, then you down-regulate like every other IVF patient. But what we do differently is this. Because of the endometrium, the inflammation in the endometrium, when you have collected your eggs, you can now collected your eggs, you can now put the patient on either GnRH or OC for about 2-3 months before you do your embryo transfer.
Correct, sir.
Sonal, Dr. Sonal,
Yes, sir.
one important thing, endometriosis is one condition where Dr. Ajay will agree with me. The Poseidon type 3 and type 4, which means that you may have in a endometriosis patient wherein the AMH AFC is less irrespective of age, or you may have AFC and otherwise good. Uh, if AFC and AMH is good, I told you on day 2 you can give a depot and then start stimulation. When you have maybe a borderline patient wherein irrespective of age the AMH is not very encouraging, there are a lot of people who do give androgens, androgel on second or third day of period, which is like poor responder. You give on second or third day of period, you continue. There are many people who do some amount of estrogen priming and try and improvise the endometrial receptivity. As regarding the dose about FSH, sir has mentioned, but there are a large number of people who feel that once more than 300, even if you give 600, it really doesn't make a big difference. So you have to take into consideration a endometriosis patient, irrespective of age, who is going to have poor receptivity. In that, you may add the adjuvants, which can be an androgel on the cycle prior. You may do estrogen priming for a few days, not necessarily the whole cycle. And then you decide the FSH, your gonadotropin dose. You may add the HMG later on, but I think so Dr. Ajay can add and clarify more on what I am talking.
Well, yes, thank you. When you even get to the realm of poor ovarian result, there's conflicting evidence about even the use of androgens. So yeah, it depends on what divide you want to stay on. So it's possible, yes, if you believe that, yes, but if you do not, then it's also another thing. But it's okay. So I'm not going to controvert that.
Correct, sir. Sir, is endometriosis fluid not toxic to the oocyte? Why should we searching for oocyte in endometriosis fluid?
Why should we?
Sir, I think they are not much clear. Why should we searching for oocytes in endometriosis fluid? In short, they are asking, is endometriosis fluid toxic to the oocyte?
No, I think the two of us said that.
Correct.
I think so. What the person is asking, that if you have done an ovum pickup and you are having good follicles and suddenly you have endometriotic fluid, you will search for oocyte because you keep those tubes which are having chocolate material on one side. The moment you are going into the follicle, you will search for oocyte. When you have fully finished all oocyte, you will still can that chocolate material because you may find 1 or 2 oocyte in that which was not in the endometrioma but was any other follicle. But uh, uh, chocolate doesn't make any difference. Oocyte depends on the stimulation, AMH, and the generic quality of the female.
Correct, sir. And they are asking, already discussed during both the talks, but clarity on, should we operate for endometrioma before IVF?
The answer is no. All endometrioma, you don't have to operate. 4 centimeter, 5 centimeter, 3 centimeter endometrioma, other ovary is normal, AMH is good. There is no statistical evidence to suggest that if they were not painful endometrioma and patient is primarily for infertility, prior to IVF, there is no role of laparoscopic surgery just to do because an endometrioma is present. It's as much as removing a 4 centimeter fibroid. Just because it is present, you will remove. It's not necessary.
Correct, sir. Again, they are asking operative laparoscopy. There are many questions. I will be taking 2 or 3. Operative laparoscopy is key to success for fertility in patients with mild to moderate endometriosis. How readily available is this technology in low resource settings, and what is the cost of this procedure?
This is a very good question. It's a very good question for Nigeria and India. And both the countries are well known for fibroid. In fact, I would tell I have 12,000 myomectomies done. So I will tell Ajay to, once the COVID situation is call me for laparoscopic myomectomy. We can remove elephants from the abdomen. But resources are relative. Like for example, in India, you may have a town which you can get property easily, so you can have more resources in laparoscopy, IVF. If you are in Bombay, Delhi, Chennai, the properties are very costly. So people use less resources on equipments or advancement. So resources are relative. Relative in the sense you have billionaires in town and you have people in lakhs in the city. So basically you have to channelize. I would give you a very simple example. My endoscopy survived on my obstetric practice. My wife is an IVF person. My IVF started because of my laparoscopic practice. Now in current time, the number of ARTs is gone down, but we are having obstetrics, abortion, laparoscopy, we have modified. So I think so you have to work in a philosophical passion that what is the best we can do. Like a lady who is purchasing a jewel or a male who is purchasing a car doesn't take into consideration I'll rent it to somebody to recover money. So you have to have best facility available in your own, and the biggest facility is here in between the two temples. The biggest resources within your mind. So you have to consider whatever you are spending. You're not spending over patient. You're spending for yourself, getting good infrastructure, so that you can deliver whether endoscopy or IVF or whatever treatment you can.
Thank you, sir. And they are asking recent management of endometriosis during COVID-19 era. Is there any impact of COVID-19 on endometriosis management, particularly IVF, infertility?
Ajay.
Yes. Yes, of course the COVID has changed our practice, and also it has affected, there was a time that even IVF treatment and all forms of surgeries were stopped because of COVID. So that probably affected some people. But one interesting study also came out at the same time saying that there is no difference in results if you delay IVF treatment by 6 months. And that was very heartwarming to me. And so that probably did not affect the outcome of the patients that we will have treated at that point in time. So, but one thing that we all know now is that if you look very closely, I have my mask. So our profile, the way we treat patients also have changed. Patients don't even want to come to the hospital unless there is every reason to come. So we see that some people who are supposed to be having treatment now are not coming to have treatment. And that is what we've said about endometriosis, especially endometriomas, that the longer you stay with your endometrioma, even without you doing anything, reduces your ovarian reserve. And therefore, and that's why one of the things we're saying, that people with endometriomas, diagnosis should be made on time so that treatment can also be given to them on time, especially as relates to their fertility. And so I think one of the things we need to educate our people more is that, well, now you can have your IVF treatment, you can have your fertility treatment. And so it's important for patients to start coming back to have treatment for even the people who have infertility and endometriosis.
Dr. Sonal, there is a very interesting thing which I observed during COVID. Of course, in September, I'll be sharing with Professor Ajay the method in which you can do laparoscopic surgery comfortably in COVID, because it is getting under publication. But what I observed is that in last 3.5 months, the number of abortions which we had in 3.5 months are equal to what we had requests for abortions was almost equal to 3 years in the past, which
Oh,
means because people were focused and obsessed with work, profession, they had no option but to remain at home, which also meant no option but to be sexually active. And there are many patients of infertility, not necessarily endometriosis, who conceived during this time. And
correct.
the requests for abortion increase. So, for example, we had 12 first trimester abortion, 2, 3 second trimester abortion. They were not necessarily endometriosis patient. So, yes, there is a halt in fertility treatment, and that is what Ajay and me are emphasizing, because a lot of treatment depends on suppressing endometriosis and giving ovulation induction drugs. So there is more opportunity for a timed intercourse, and I'm surprised by plenty of people who get pregnant during this time. Now, if you're talking about patients of endometriosis and low AMH, I think that's a tricky area because 6 months waiting and all
Yeah.
may have marginal effect. But overall, I think so. People, if if you make them less anxious, they are comfortable in this lockdown to fertility issues because they know there are too many things to be focused on. And when
So,
you're disconnected, people become pregnant.
correct, sir. So the effect of stress and anxiety on infertility, and that has shown in COVID time. Sir, last question to you. For a case whereby the ovaries are buried under adhesion, how best in terms of surgery if needed, so that the eggs can be harvested for IVF?
It's a very good question. And I like this question because, uh, the first IVF pickup I had done in 1992 in Clermont-Ferrand, in John Pooley's place, where I had gone actually for laparoscopy at Clermont-Ferrand under Brua and Arnaud Vatiers. Now, when there is adhesion, when you have good stimulation and follicle, personally, I find there is no difficulty in doing ovum pickup. So there is unnecessarily no need of laparoscopically mobilizing and destroying those adhesion. You remember if there is 20 millimeter multiple follicle which are in fixed position, which makes your ovum pickup easy rather than difficult. Because if the ovary is free, the lateral follicle, your ovary can get tossed when you're doing the last follicle. Here are some adhesions. So personally, I feel nobody should do anything to remove adhesions to make ovary more accessible. They are adherent, they are stimulated, you have follicle, ovaries are fixed, best for a pickup.
Right, sir. Sir, can I take two, three more questions?
You can take as many as you want.
Fine, sir. Sir, there is a patient excision laparotomy a year ago because of endometriosis, and since 7 months back, the patient is not getting, not ovulating. Uh, how do you see the prognosis?
See, one important thing about open surgery, sometimes you dig a mountain and get a mole out of it. So I think so for any endometriosis, laparoscopy eventually or anyway, it is the best method. If somebody has undergone an open surgery, which I told in my opening slide, that 64% will be below 30, and everybody is not going to go to a laparoscopic surgeon. So there will be few patients, but if there is an open surgery done, she's not ovulating, you have to get her AMH. I think so. It is wise to do a hysteroscopy. There is no need of doing a laparoscopy and complicating the matter more because you'll find more and more adhesions inside. If AMH is not bad, hysteroscopy is good, then she's a good candidate to do a good IVF, give her a result. And I have seen in worst of endometriosis, when we do a cesarean section, all those endometriosis have disappeared because of enlarging uterus. The uterus enlarges posteriorly, and all those endometriosis and adhesions are gone, and suddenly you are surprised that when you're delivering cesarean, you try and turn, most of the endometriosis is sorted.
Right. Thank you, sir. And there is another question. A patient operated for a fibroid, and they are not clarifying how it was operated, and always bleed from the navel on day first or second of her period. So, what
Always
could be
what?
the treatment? Sorry, sir.
Always what? Second day of
She bleeds from her umbilicus on the first or second day of period.
fibroid is a huge chapter. See, we have 12,000 plus fibroid removed, 20 centimeter, 18 fibroid removed. We have the largest series of more than 500 plus in-bag morcellation. Anything about fibroid, we have worked for 25 years. Now, what she's having is actually, she's having a port side problem,
Hmm.
which is something like a port side endometriosis. So there can be port side fibroid, there can be leiomyomatosis. So probably somebody who has done the myomectomy, for whatever reason, there's some amount of uterine tissue or some amount of tissue, maybe a little bit of whatever it is left. So she's having cyclical bleeding from the port side. And if there is a mass-like thing, it should be excised. If it is not like a mass-like thing, then fertility should be treated separately from this. And you have to counsel her that this can happen, because any other colleague is like us, so you don't have to run down any other colleague. But this can happen, but it's a port side problem and quite likely to be port side endometriosis.
Correct. Ajay sir, they are asking how long infertility treatment for endometriosis can be done. Means how long if they are not getting result, up till what time it can be treated.
How long the fertility treatment should stop? Is that
Yeah.
the question?
Yeah.
Yes. The thing is to, just like I said during the presentation, have a good assessment. Why is the pregnancy not coming? Okay. And then the patient ultimately decides when they're going to stop, or the couple. All right. Because I've seen people who have done 11 cycles, not even from endometriosis, before they got pregnant. Okay. So when it comes to IVF, we don't have guarantees, you know. So one of the things that we probably have to be looking at is the decision making. Is she making eggs? You know, if she's not making eggs, do we need to use donor eggs? But if she's a young woman, she's making eggs, and then you want to pull the embryos together. So those are the decisions you just need to continue to make. And then, but sometimes also some of the patients take a break and come back, and some, okay, they just say no. But it's not a doctor in a doctor's place to say you must have this number of cycles and then call it a day.
I think so. One
Correct.
very important thing, Dr. Sonal, is how you counsel the patient. How long the patient will have treatment can be framed as how long the patient will stay with you. So the first important thing, as he rightly pointed out, that you have to counsel, interact, keep the confidence of the patient, maintain 1 or 2 cycle break she wants. You allow her to have a break depending on what the situation are. Counseling and explaining the patient is very important, because they get financially drained off. Their husband and relative are worried that so much injections you're giving, what is the side effect on the patient. So keeping patient's confidence intact allows you to treat her for a longer period of time. And as Dr. Ajay mentioned, if she's not giving adequate oocytes, hysteroscopy is normal, start suggesting her for an alternative option, which can be donor oocyte. Fortunately, in endometriosis, the frank need of surrogacy, like in adenomyomectomies or adenomyosis, is not there. But I think so you have to consider the patient couple as a part of your family, and you have to keep their egos and pamper her with confidence. so that they don't lose faith, because when they change a doctor, everything starts again, and the first 4 cycles done at your place, the fifth cycle done at their place is like the first cycle in your place. So it's better that you counsel them and you tell, okay, look, we are interested that you should conceive. This is best for you. This is our best suggestion. If you feel, please take 2 months break, focus on Netflix or this or that or whatever it is, and have an on-off mechanism wherein 2 months, you remain a little silent. You may put them on something like Dynogest or some other drugs, tell them not to worry, and then come back.
Thank you, sir. Sir, they are asking, I had once came across a patient who had endometriomas in her lung cavity, leading to repeated coagulation of chocolate colored fluid in the cavity during her menstrual periods. Is it safe to say that she may or may not have endometriomas in the reproductive area? And if not, does this still affect conception, and how it can be managed?
Endometriosis can reach anywhere: ovaries, tube, bowel, appendix, diaphragm, lungs, episiotomy, cesarean scar, anywhere. You have to understand that even though the lung endometriosis doesn't affect a fertility, but a good laparoscopic surgeon, along with an anesthetist who doesn't mind to have one side lung collapse, you can excise or drain that endometrioma along with, usually the laparoscopist is the main person who is doing surgery, but there is a chest surgeon around, and the anesthetist is very much aware, because the moment you touch the diaphragm or diaphragmatic endometriosis, if you open, there is little amount of collapse. Don't panic. Don't panic. In fact, you can still treat a lot of endometriosis. Lung and diaphragmatic endometriosis is independent of fertility issue, and that should be managed by multiple discipline in a proper atmosphere, in proper, best done by laparoscopy rather than digging the whole mountain and reaching to ocean and craters.
Yes, sir. Ajay sir, please, what is the effect of severe hyperglycemia, diabetes mellitus on the outcome of ART? It is not related to endometriosis. They are asking effect of hyperglycemia on the outcome of ART. And also, will you recommend deferred embryo transfer for a 35-year-old woman with previous failed attempt due to oocyte, endometrial, and male factors?
Please, I got the first question, but the second one.
Second one is, will you recommend deferred embryo transfer for a 35-year-old woman with previous failed attempt due to oocyte quality, endometrial, or male factors?
Due to poor oocyte quality, endometrial, and male factor.
Factor or male factors?
Okay, thank you. Yeah, well, hyperglycemia will affect the chance of a woman getting pregnant. And so that needs to be diagnosed and managed before actually you do IVF. So blood sugar monitoring, actually, most IVF clinics will be part of the investigations that you're going to do, check for your blood sugar. So, because we know that hyperglycemia also affects embryogenesis. So if you get pregnant and your blood sugar is not controlled, then the baby also can be affected, and then the blood sugar can also go into the roof. So hyperglycemia and ART outcome, they're not friendly. So it's important that we screen for hyperglycemia and treat even before you do ART. The second question, deferred embryo transfer does not take care of bad embryos. It only takes care of the endometrial receptivity. Okay, so you know that if poor egg quality, poor sperm quality, what it will affect will be the embryo, the quality of the embryo. All right. So if the quality of the embryo is bad, deferred ET has nothing to do with that. When we talk about deferred ET, when you have polycystic ovaries, where we think there can be dysynchrony between your embryo and the endometrium, because it's an endometrial issue that we're looking at. And then also in endometriosis also. But if your embryo quality is not great, deferred ET will not solve that problem. We know that when a cycle fails, about 70 to 80% of the time is from the embryo. So, and therefore, just like we said all along, what your stimulation protocol, but most importantly, the things that you use to generate the embryo, which is the sperm and the egg. And more importantly, the genetic composition of the two of them. If there is a problem with that, then deferred ET will not solve that problem.
Correct, sir. Sir, how do you manage endometriosis causing pleural effusion and fluid that is bloody? Endometriosis causing pleural effusion.
Yeah, I think that's the last question that Prakash answered about
Yeah.
Go ahead, Ajay. Of course, pleural effusion, there is only one thing. If it is bloody, the pleural effusion is taken off, you give depot preparation, suppress the endometriosis, you give proper treatment which can reduce, which you can believe in long duration of giving Dynogest or giving a depot preparation. You have to keep it quiet, you have to do chest physiotherapy, and you have to keep a close watch, because anybody can survive with one good functioning lung. So effusion can be drained off, but the endometriosis in that pleural cavity doesn't disappear without add-on medical treatment. So that is to be always added.
Sir, thank you for giving us very practical I must say the talks, and the question answer session was also very tricky, and all the viewers have congratulated you, both of you. Thank you on behalf of INTAS.
Yeah,
I think Mr. Janardhan is there.
Yeah, I
madam.
would like to
Sir,
thank.
thanks a lot.
Yeah, Janardhan,
No,
I would thank
After you.
Dr. Ajay. Dr. Ajay, it was a pleasure to be sharing the endometriosis and infertility ART with you, Dr. Sonal Mehta. INTAS people are here, and I would like to make few things. 12 o'clock African time, tomorrow we'll have endometritis. I think so they will give the INTAS people. Then on 9th Sunday around again 12 o'clock, we are going to have cryobiology in ART. So every Sunday in the afternoon, Ajay Abayami and we and through INTAS will be in contact. So whatever programs we have, we'll give you the link. We'll follow, we'll take your link. And most important, Ajay, after the COVID and traveling starts, I'll be coming to Nigeria for laparoscopic myomectomies.
It's the date.
And thank you, Satpati, Janardhan.
Sir, thanks a lot. We are very much thankful for both of our eminent panelists for such a beautiful presentation, backed by so many evidences, backed with video, backed with so many studies, and the kind of questions, the kind of this Q&A session, which lasted for almost 40 minutes, it itself shows that the audience was very much interested into this kind of discussion for this session, and they have really enjoyed. Once again, sir, on behalf of INTAS, I'm very much thankful to both of you for sharing this platform together.